So good afternoon to this spotlight session. I'm very happy to be here with David Tate from Ghent, Belgium, Roberta Maselli from Milano, and Arnaud Lemmers from Brussels. And the purpose of this discussion is to ask our three experts some answer about what should we know. You do to want to learn poem, and poem is something which is becoming more and more standard. So what should you know and what should you learn? And I think this is very important to have an overview of the different steps of the training and the requirement when we do poem and we deal with this patient with motility disturbance. Maybe my first question will be to Roberta. Before embarking in doing poem, what do you think is necessary in terms of an environment, skill, knowledge from the trainee?
Yes, we're starting with a very good point. The first things to me is not only the trainee, but also the environment, the team, because it's not one single operator procedures, but all the team stemming from the nurses, the assistant, and the equipments that you have must be really ready and keen to arrive to this third space procedure that nowadays seems so, let me say simple, although it's not a term that I like, but let's say simpler than when we thought some years ago, because we were so fair about complication and a lot of different things, and nowadays, you know that in some centers they use poem as the first part of the training for the third space, because it's much more standardized. So the key word is standardization of the equipments, team, and the operator. But coming back to the skillness, I think for third space in general, and in particular for poem, what is needed is the control of the tip of the scope and the full control of the movements that you are doing, and the basic knowledge in what are the planes and what are the steps of the procedure. So at the beginning you don't go directly to go for the full procedures, but then you divide and you split them into different tasks, as everything we are learning in life, not only in endoscopy.
Okay, and what about the knowledge of motility disorders? It's also a background.
Yes, I wasn't right directly to the treatment because it was poem, but for sure you need a good indication, and also in the team, somebody expert in physiopathology, and also you that you are the performer one, you need to have the basic knowledge of the manometry, HR manometry, but also how to look at X-ray barium swallow, and also in gastroscopy, because the first suspicious most of the time by the indication that the index gastroscopy comes from there.
Okay, thank you. My question to David, which would be the key technical steps before embarking to the first patient, whatever the first patient is performed independently or under supervision? Are there some technical requirements, some previous experience which is required?
I think certainly there are, and so the person that starts to think about performing poem needs to have some background. Of course, they need to be competent in gastroscopy, they need to be able to treat bleeding, they need to have all those basic techniques, they need to be probably doing colonoscopy and basic polypectomy, certainly. And then, I think I slightly agree with what you say, Roberta, about poem being a place where you can start to explore the third space. And in this curriculum, the two-part curriculum that we're here to talk about, the second part was a deconstruction, as you said, of exactly how to perform a poem procedure. But before you got there, the pre-requirements were gastroscopy, therapeutic gastroscopy, colonoscopy, therapeutic colonoscopy.
The animal model or simulation or not?
Yeah, this was a contentious issue when we made it, but in the end there is a recommendation in there for animal procedures.
And then at one point you will go to treat real patients. So I remember the first time I did a poem was 15 years ago or 14 years ago. I was very impressed because making a hole into the esophagus, looking at the mediastinum sometimes, was very stressful. So at that time, we are still, even if we know that it's a relatively safe procedure, we are still afraid about complication, especially at the beginning of experience. So which would be the key step, Arnaud, when starting the first patient?
You mean the key step technically that we need to encounter is I think we need to have a very clear view of the different steps of the procedure. And this is what you need to explain and to train your fellow, of course. So the steps are to have an evaluation of the landmarks of the esophagus, then how to do the mucosotomy and to create the tunnel, and then to create the tunnel, and then to perform the myotomy, and then to close, of course, because this is the key. So if we want to elaborate on those different steps, it's very important first to ensure there is no squamous cell carcinoma. This is something we can forget. To clean up the esophagus, to have a very good overview, and then to know about the gravity. Where is the anterior wall? Where is the posterior wall? Where is the junction? And to take all those measures. This is, of course, the key. And then to start with the opening. So the opening, you need to inject, to lift a certain amount of liquid in the submucosal space, to open at least 2 centimeters to be able to enter with the scope. And maybe it's one of the most difficult parts of the procedure. So maybe not the one you need to train your fellows at the beginning. When you can enter with the scope and you can use a conic cap for doing that, it's more easy. Then it's straight, and you need to tunnelize alongside the muscle layer, preserving, of course, the top, because this is the most important part, is to preserve the mucosa and the superficial submucosa, to expose the muscle layer up to the junction and to go a bit further in the stomach. And then there are tricks for performing the myotomy, of course. The one is to know where to start performing it, because you need not to open the muscle layer in front of your mucosotomy, at least 2 centimeters down from the distal opening, and to use the proper method for performing the complete myotomy or partial myotomy, so the selective circumferential one, with the right length, of course, extending 2 centimeters into the stomach. And then closure is very important, because you need to ensure to create this kind of suturing technique by placing the first clip distally, ensuring you approximate the edges, and then to close completely, of course, your mucosal entry.
So we would all recommend to start under supervision of an expert, but you would even recommend to start with a supervision step by step, not allowing the fellow to do all the procedure at the first time. When you are sure that the easiest part is controlled, then you move to the next part.
So the first would be when you are in the tunnel to give the scope probably, and to ensure that you can safely follow your plane straight alongside the muscle layer, trying to preserve vessels, and to, of course, not take too much risk in terms of bleeding, and just expose the muscle layer. And then next step will be the myotomy, and next step will be the entrance, and the closure is very important also. So this is how we can proceed with good quality training.
Just one very short point. None of you has spoken about previous experience in submucosal dissection. We agree that this is not mandatory to do POEM, or?
So it's not mandatory, but of course, probably you will be much more having you will have a quicker experience in proficiency doing the POEM, because you recognize the layer, you have better control in terms of vessel management, recognition of the different layers, and you have also the control of the tip of the scopes, and all those skills you bring this experience from ESD. It's not because you have the experience doing ESD that you can go for POEM without any training. I think it's not the same procedure as whole, so you need the training, but you can enter the world of POEM expertise by starting with POEM, or you can start by having experience with ESD before.
And vice versa. Okay, so now the next point is, of course, again, at the beginning we were afraid about the procedure, we were preventing the potential complication. I remember that we were giving antibiotics for 1 week, we were keeping the patient for 2 days, we had the risk of potential bleeding or mucosal break. So what would be your recommendation for prevention of adverse event?
So cleaning the esophagus, that is very important. That is exactly what we are doing in the colon, for example. You don't go for any advanced procedure if you don't have a clean field. And in POEM is even more important because you are opening the mediastinum that officially is sterile. You know that we've done a study on this also in understanding if it's the case to give antibiotics after it or to spray antibiotics in the tunnel as we were doing at the beginning. And there's no evidences that adding antibiotics after the procedure is helping you somehow. So the only things that you have to take care is the fever. In case the patient has fever after the POEM, you should go, at least it's the protocol that we are using in our center, directly for a CT plus contrast oral medium, plus contrast per oral. Because in that case means that you have not only an inflammation, but there's a suspicious of a leak or a clip or an opening of the mucosa. So the first thing is cleaning. One of the other topic is the presence of candida in the esophagus. I know that there are some centers that they are still doing POEM even if you have candida. We don't have enough data to say if it's safe or not, honestly, I'm lying in one of those centers that are not performing POEM with candida. This is why I scope the patient, all the patient before, just the same day before the procedure, before the intubation, to clean the esophagus, so I'm decreasing the risk of aspiration during the intubation for the anesthesiologist, because just remember that the surgeon with the Heller myotomy, they are placing an nasoesophageal tube to clean the esophagus, but because we are endoscopy, we should clean, see with our eyes, everything is possible. Sometimes we found some ulcers in the, very deep ulcers in the junction, that is one of the other, could be one of the other contraindication for POEM. So I'm cleaning to avoid the aspiration, to check the esophagus for ulcers and also the presence of candida. This is what I am done.
And then we do the procedure. David, do you keep the patient overnight? Do you give sometimes antibiotic therapy? Do you do some systematic control endoscopic or fluoroscopic or CT scan, or everything is obsolete?
Yeah, there was a lot of discussion about this as well when we wrote this. So the answer is that most people are keeping the patient overnight for one night. Most people are giving peri-procedural antibiotics, but not antibiotics after that. And the majority of people are not doing any, either radiologic or gastroscopic control the day after. But there is if you look in the document, there is an evidence review of that, and those are the recommendations that came out.
And then, of course, like in every advanced procedure, and maybe it's a question to Arnaud, but I would like to hear the comments of the three of you. How do you document your performance in terms of clinical performance, effectiveness? Do you do some quality measurement? Do you recommend to evaluate a registry for your outcomes and something which is systematically followed, not only for potential complications, but for outcomes? And even more, when do you consider repeating a therapy and so on? Maybe Arnaud, you may...
Yeah, so it's clear that the question of the competency, of course, you need to have all those steps that you perform properly, but it's not a question of speed, it's a question of effectiveness in your patient, and to be sure that you have the clinical response, that it's associated to the report rate in the literature, that you have a safety, you do not have so many complications. So the only way to be sure about that is to have a registry, of course. I think there was a very interesting work from your side about how to assess the people in their skill. Maybe you can comment on that.
In the document, so in the part 2, there are 2 parts to this. The second part, we put a competency assessment framework in it. So it's not validated. We declare that up front. But it is based upon the steps that we recommended in the curriculum. So we had a whole section on, for example, injection technique, tunneling technique, and what's good, what's bad, right? And this was all put through Delphi consensus. So in the end, what is in the document is a competency assessment framework, which we called PPAT, Precision POEM Assessment Tool. And that is in the supplementary data, and we plan to go ahead and validate that on a blinded image review by the expert panel. So I think we can come soon with an answer to the question, an individual poem procedure done by a trainee, what is the quality of that procedure as best we can give, and that also gives, of course, a trainer and a trainee a common language to say, okay, I'm the trainer, you're the trainee, this is how we're going to assess you. You can read it beforehand, you can watch all the best practice so you understand that that's how we're going to assess you. And of course that doesn't mean that everybody has to do poem in the same way, no. But there are clearly, if any of us watches a poem procedure, we will clearly have an opinion about whether the quality of it was high or low, and that's what we try to put in the document.
I have a slight different opinion about the speed. So I don't want the procedure to be faster, but I want the procedure not be too long. And at least in my center, I have some strict rules that the poem procedure must not overcome 1 hour. 1 hour is the limit. Otherwise, I'll take the scope and I'll do it. So they know that is 5 minutes for the entrance, 20 minutes for the tunneling, 20 for myotomy, and 5 to close.
Okay. But you are patient if you take the scope
Yeah.
only after 1 hour. It's good.
No. I mean, this is why I cut down into the 4 different steps.
Yeah.
So it's not only 1 hour, because you can spend 1 hour in entering if you are really at the beginning of your training. But the first thing to me is the safety of the patient, and the more we spend, then the more you have gas-related adverse events. That in poem is not like in the ESGE, it's quite different. You can have very big emphysema everywhere in the body.
Even with CO2, and of course,
Exactly.
never do a poem with
Exactly.
air
This was the
insufficient.
equipments,
This
the
is
basic
something
equipments.
that we didn't mention, but it is so obvious. So thank you very much. I hope that we learned something, at least from my side I learned something, and the publication in which David coordinated will be available soon, or maybe today
probably
in
a
endoscopy.
couple of weeks in endoscopy.
In a couple of weeks. So if you are more interested in training in poem, have a look on this publication. Thank you very much. Thank you.
Thank you very much.